Halo.
Ya, thank you.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Eddy. Bismillahirrahmanirrahim. Good afternoon, ladies and gentlemen. On behalf of our organization, Indonesian Gynecological Endoscopy Society, I would like to declare this webinar meeting is now open. As we open this meeting, it gives us a great pleasure to welcome you all. In particular, I would like to express my gratitude and warm welcoming to our plenary and future speaker, as well as the presenter, especially those who are coming from overseas. I would also like to express to Haifu and PT Triadi Lintas Persada, the main sponsor of this meeting. Its support and contribution are important, not only making the conference happen, but also inform us about the new non-invasive modulation in gynecological treatment, as mentioned by Dr. Eddy. Let me say thank you to our honored guest speakers, Professor Zhang Lian and Professor Aixingzi Aili, and our internal speaker, Dr. Ichnandy and Dr. Relly, for their contribution in this meeting. Topic of this meeting is from minimally invasive to non-invasive surgery, the latest advancement in gynecology. This meeting will inform us a new technique and new instrument has advantage as non-invasive. We hope this meeting give us more experience and more knowledge about the new modalities in treatment of gynecologic condition. Now, the webinar meeting is open. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Nadir, for the welcoming speech. I will ask Dr. Darmawan from Indonesian Medical Associations to talk about ethics. Please, Dr. Darmawan from Indonesian Medical Associations, Eddy, Branch Jakarta.
Thank you, Dr. Eddy and Dr. Nadir. Good afternoon, dear colleagues, especially our colleagues from international as international speaker. Thank you for the opportunity given to the Indonesian Medical Associations. So let me remind our medical ethics in Indonesian language, because it is mandatory instruction from our President of Indonesian Medical Associations. Maybe I will only take about 7 minutes. Nah, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera teman-teman sejawat sekalian. Nah, saya mengingatkan sedikit tentang etika dasar bagi dokter. Jadi sebetulnya memang ini harus di-remind berulang-ulang. Saya mungkin tidak memberikan banyak contoh karena sudah beberapa kali juga di bidang ginekologi ini saya memberikan mungkin pembukaan di bidang etik. Next. Jadi seperti kita ketahui bahwa aspek profesi kita itu pertama membutuhkan kompetensi atau keahlian. Oleh sebab itu kita juga perlu ikut selalu update, selalu menjaga kita punya kompetensi. Senang sekali teman-teman bisa terus mengupdate ilmu ginekologinya dan mengembangkan ilmu ginekologi di Indonesia. Nah, teori-teori yang sistematik dikembangkan dari body of knowledge kita dapat dari standar pendidikan kedokteran Indonesia. Senang sekali bahwa progres ke depan banyak masalah-masalah atau banyak penanganan ginekologi yang mutakhir mungkin akan diajarkan di SP1, jadi tidak semua selalu di SP2. Kita memiliki kode etik dan orientasi utama kita adalah melayani masyarakat. Dalam kode etik ini juga kita perhatikan ada beberapa aspek, yaitu yang umum, kemudian dokter dengan pasien, dokter dengan dokter, dan dokter dengan diri sendiri. Untuk itu, kita juga mesti memperhatikan nanti bagaimana kita menjaga kesehatan diri kita sendiri di era COVID seperti ini. Kemudian juga kita harus ingat adanya MKDKI. MKDKI itu terutama berkaitan dengan disiplin kedokteran ya, bukannya DKI itu daerah khusus ibu kota. Jadi semua SOP, mematuhi aturan-aturan, undang-undang praktek kedokteran itu semua diaudit atau diperiksa oleh MKDKI apabila kita mendapatkan sesuatu pemeriksaan ya. Oke, next. Nah, prinsip yang berlaku umum tentang etika ini adalah prinsip keadilan, timbal balik, dan kesamaan hak asasi manusia. Kemudian hormat terhadap martabat manusia sebagai pribadi, ini adalah prinsip-prinsip yang umum dan kita harus utamakan. Sedangkan nilai-nilai yang lain mungkin bisa kita perbandingkan dengan prinsip-prinsip ini. Next. Kemudian kita lihat bahwa ada etika normatif. Etika kedokteran adalah bagian dari etika spesialistik. Nah, kemudian kalau kita lihat di sini, masalah pokok dalam etika normatif, itu bagaimana kita mempertanggungjawabkan secara rasional penilaian dan putusan moral kita. Putusan dan penilaian moral yang dapat dipertanggungjawabkan secara rasional adalah penilaian dan putusan yang didasarkan atas prinsip dan norma moral yang sehat, yang baik. Jadi kembali lagi kita harus memiliki pemahaman nilai-nilai seperti ini ya. Next. Saya suka memberikan contoh kalau di bidang SpOG itu mungkin misalnya pasien minta supaya direkam, sedangkan kita punya aturan untuk tidak boleh merekam di rumah sakit. Nah, kalau kita menolong pasien kemudian direkam itu bisa berbahaya buat diri kita sendiri. Lagi pula nilai menolong pasien adalah nilai kehidupan yang lebih tinggi daripada nilai estetik atau nilai pengabadian ingatan melalui rekaman atau melalui foto. Jadi hal-hal seperti ini harus kita bisa juga menjawab apabila pasien berargumen bahwa mereka mempunyai otonomi berhak untuk merekam kejadian yang membahagiakan misalnya. Nah, ini adalah contoh etika normatif di kode etik kedokteran Indonesia. Kewajiban umum pada pasien seperti tindakan profesional dan independen, jujur dalam menerapkan ilmu dan keahlian kita, memberikan keterangan hanya pada hal yang diperiksanya sendiri, terkait dengan surat keterangan sehat maupun surat keterangan sakit. Jadi hati-hati juga surat keterangan sehat ya. Melindungi setiap hidup insani dan menghormati martabat kemanusiaan. Mengenai surat keterangan itu juga kadang ada masalah dengan asuransi ya. Jadi hati-hati. Kemudian merujuk pasien kepada ahlinya. Nah, ini juga ada hal seperti belum lama saya dapat kasus obat psikotropik diracik yang fiturnya sama 2 macam dengan dosis maksimal dua-duanya 2 mg dan 2 mg itu dalam satu kapsul. Jadi bukan soal ini pasien siapa, kebetulan bukan spesialis psikiatri yang meresepkan, dan masalahnya ada kesalahan gitu loh, bahwa fitur yang sama diracik dalam satu kapsul. Beda kalau misalkan fiturnya berbeda. Nah, kemudian merahasiakan segala hal tentang pasiennya, ini tentang kerahasiaan pasien. Next. Prinsip moral dasar yang harus kita perhatikan, yaitu prinsip sikap atau kehendak baik mendahului prinsip lain. Jadi kita selalu mempunyai kehendak baik, bukan kehendak lain atau bukan niat lain di balik apa yang kita lakukan dalam melayani pasien-pasien kita. Prinsip tidak melakukan yang jahat atau merusak atau merugikan, kemudian prinsip melakukan yang baik, prinsip adil, dan prinsip otonomi. Jadi ini otonomi pasien apabila pasiennya berkompeten ya, otonom. Kalau pasien gangguan jiwa tentunya tidak bisa berkompeten terhadap dirinya sendiri, oleh sebab itu diwakilkan oleh keluarganya. Demikian juga pasien anak. Next. Saya pikir hanya itu yang bisa saya berikan untuk reminding saja, supaya tidak lama-lama memakan waktu, dan semoga apa yang sedikit saya sampaikan bisa kita sama-sama mengingat kembali tentang praktek etik, dan sebetulnya satu lagi adalah tentang patient safety yang diingatkan oleh Pak Ketum kita, Dr. Daeng, supaya kita selalu memperhatikan hal tersebut di era yang penuh atau cepat berubah seperti ini. Terima kasih, selamat sore, wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you very much, Dr. Darmawan.
Salam.
We come to the session, the first sessions. Dr. Nandi will talk about general treatment modalities for fibroid. I will read his CV. Dr. Ichnandy Andi Rahman SpOG, born in Jakarta, 1977, studied at Faculty of Medicine, University of Indonesia, certified as a general practitioner on April 2003, certified as an obstetric and gynecology on July 2008. Interest in fertility and laparoscopic surgery, had an advanced laparoscopic training in Maxima Medisch Centrum Maastricht University, Netherlands, currently as course director of the Indonesian Gynecology Endoscopy Society, IGES. Current appointment, private practice as Gleneages Medical Center. Oh, sorry. Is in the Kartika Minimal Invasive Gynecology, Presidential Hospital Indonesian Army Central Hospital Training Center, and also active as national and international speaker and instructor. Okay, Dr. Nandi, please. The time is yours now.
The introduction, Dr. Eddy, my senior, my teacher. Hello, everybody. I would like to share my screen now.
Mohon izin, dokter. Ada satu video yang ingin ditampilkan.
Video?
Oh, yes.
Turn on the video before the speakers, the first speaker, Dr. Edwin.
Yes.
Yeah, okay, please. Sorry, Dr. Nandi.
The sentinel as it shows up, and you can see that the assistant that does the camera work, she moves closer, so the sentinel is shown stronger. And we can see when the camera moves away, the signal gets weaker. In some systems, it's possible to adjust the sensitivity with several little tricks like shutter speed or just by software. But the strongest method to get the signal better is just to move closer. And that will work, obviously, with any device there is. So what we see here is the iliac vessels on the left side, and right in between, there's a sentinel, and there's also the lymph vessel coming along the pelvic wall. This is probably the obturator nerve. And sometimes, even if you have a sentinel, it makes sense to follow the vessel a little bit. Maybe you find a second one, or in the other direction, even a third one. In this patient, we also put some fluorescence up the ureter. So in the right-hand side on the bottom, you can see the ureter. Sometimes this is helpful to have it show green, so you will always notice it.
Okay, thank you for the sponsor. Maybe we can have Dr. Nandi to show his presentations. Please, Dr. Nandi.
Okay, thank you so much, Dr. Eddy. Good afternoon, everybody, our distinguished speakers, Prof. Aili, Prof. Lian, Dr. Lee, how are you? My senior, my teacher, Dr. Eddy, Dr. Relly, Dr. Eddy, everybody, thank you so much. So, thank you for having me in this prestigious event. So, in this webinar, I'm given a topic about general treatment in modalities for fibroids. So, for disclosure, I don't have anything to disclose. Okay. Now let's talk about myome. So uterine fibroid, also known as leiomyomas or myomas, are the most common form of benign uterine tumors. And it is affecting 60% of women in reproductive age and almost 80% in all women during lifetime. So the risk factor, we all know about the risk factor. It's about race, age. If we know that in African American women are more higher compared to the Caucasian or even to the Asia, and then especially about regarding age, about if the women around 35 years of age, the incidence of myome is a bit higher compared to those in the 45. And then, as we all know, that early menarche is also having a factor in a specific disease. And then, unlike parity, who's having a protective mechanism in fibroids. So during pregnancy, most of the fibroid is not enlarged. And then there's also other factors like obesity, high blood pressure, and then caffeine, alcohol is also a factor that involved in the fibroids. So we just have a quick refresh. There's an according to FIGO classification, that we have an eight type of myomes or fibroids. The first one is the one who's pedunculate type 0, which is fully pedunculated in the cavity. And then the type 1 is submucosal, which less than 50% of it in the intramural. The second one is also submucosal, the type 2, but more deeper into the myometrium intramural. And then we have the one, the type 3 is a fully intramural, but it's having contact with the endometrium. Type 4 is a fully intramural. Type 5 is a subserosal, but which is more 50% of its fibroids light in the intramural. Type 6 is also subserosal, but less than 50% of its parts in intramural. Most of its parts is already subserosal. And there's also pedunculated subserosal. And then there's other type of myome in the adnexal or in the pelvic cavity, which is not connected to the uterus. So the thing is, the type of the myome, the size and the position of the myome will accordingly to the symptoms that happen into the women. So as you know that most of the intracavitary fibroid will causing bleeding to most women, and then it also sometimes the severe bleeding can cause about also anemia. And then regarding the size, the bigger the myome, the more pressure it can give to other part of the women's body. And then it's also sometimes if the women if the fibroids is on the anterior side and it's pushing into the bladder, it can cause the urgency into the women. And then if the big size myome on the posterior side of the uterus, which can give a big pressure to the rectum, it will cause a bit of constipation. And then if the position of the myome itself is a bit more lateral, it could cause some pelvic pain, and then sometimes it could cause some hydronephrosis, something like that. And then some of the myome could impair the fertility. So sometimes the patient come without any symptoms, but only for a fertility treatment. And then from the anamnesis, we know that, oh, madam, you already been through some miscarriage. And then when we perform the transvaginal ultrasound, we could see there's a intracavitary myome. So most of the symptoms is depend on the location and depend on the oh my god. Yes, depend on the location and size. Okay, and now regarding management. So since we are in this IGES webinar, IGES is a surgical management. So most of the management we know is surgical management. We could have a hysteroscopic myomectomy like TCRM, and then we also could have the abdominal myomectomy, laparoscopy myomectomy. And then if the woman is not in need of another further fertilization, we could have hysterectomy that could be done with abdominal or into a V-node technique. And there's also non-surgical alternative. There's also medical therapy, which we will not discuss in this webinar. There's a uterine artery embolization. And there's also the new one, the new method is the non-invasive surgery, is the HIFU technique, which will be described by Professor Lian and also Professor Aili. So we all know that since in the beginning of the surgical time, myomectomy is better compared to hysterectomy. Why? Because you're not cutting out any organ. And then you're not causing any deformity in the women. So it used to be the very first choice of fibroid management. It was set by Victor Buni back in 1946. And then it was also Buni who performed the myoma enucleation, and continued by Newworth and Amin with the hysteroscopic myomectomy, Kurt Sam with the laparoscopic myomectomy, and Dubois with the largest case of myomectomy. So, according to ACOG and ASLM, it's clinically apparent myomas are significant concern to the patient if otherwise asymptomatic. When it causes excessive bleeding or anemia, and when it causes acute or chronic pain, and then when, like I mentioned before, the size of the myome can giving a pressure or box symptoms with a significant urinary problems, and then we do not find any abnormalities, then we should perform myomectomy. And also, if the patient come with infertility symptoms, with the distortion of the endometrial cavity or the tubal occlusion caused by the box symptoms of the myome, we could perform the myomectomy. So of course, compared to the classical abdominal myomectomy, endoscopic myomectomy is more advantage. We have faster recovery, we have shorter hospital stay, we have lesser blood loss and decreased adhesion of formation, we have less pain, and then in the infertility patient, we could try to repair the cavity and the tube itself. So, but the problem is, laparoscopic myomectomy is technically challenging procedure. with a surgeon-specific limitation. The biggest the challenge, and then of course the ability to suture the myomectomy sites. And then factors such as size, number, and location of the myoma, of course, influence the choice of the operation. And then 20 years ago, the contraindication mostly relatively about myoma more than 4 centimeters, or if it's intramural, or if it's in anterior. And then most of the contraindication, if it's bigger than 6 to 8, and then if it's more than 3 fibroids, and of course, if we facing the adenomyosis is also quite challenging. But during times, with the increased development and advancement in the surgical technique, the limitation of laparoscopic myomectomy has become lesser and lesser. They used to say that the myomectomy is appear to effective if the myoma is not larger than 10 centimeters. But we all know that most of the day now, people can do it more or bigger than that size. And then Alfonso and the late Ornella already stated that laparoscopic myomectomy is safe and reliable procedure, even in the presence of multiple or enlarged myomas. That's why becoming now laparoscopic myomectomy is the choice of most fibroid symptoms women. So the late Rakesinha says that the modification in standard technique of laparoscopic myomectomy and innovative use of morcellator enable efficient performance of the procedure in the all patient regarding all the size, location, and numbers of myoma. So the late Rakesh says that laparoscopic myomectomy can be performed by experienced surgeon regardless the size. So size is not a problem anymore. We all know that even after he's gone, Rakesh is still holding the world record for the biggest myome to be taken out by minimally invasive procedure. So the thing is, we need to have a good preoperative preparation, and then we customize the placement of the laparoscopic port to the location and the size of the myome. And then we also choose the right scope. Sometimes we need 0 degree, sometimes we need 30 degree. And then the use of vasopressin is very useful. Or back in 2011, 2012, when in Indonesia we don't have vasopressin for doing this, we can do it without vasopressin, just do the arteriuterine clamping or ligation, and then we can do it. And also, if we are having a difficult laparoscopic operation field, we can use direct morcellation techniques. So Rakesh says that if the surgeon ability to perform the procedure is unlimited, then the size does not matter for the performance of myomectomy laparoscopically. So each surgeon has to determine selection criteria based on personal proficiency, especially intracorporeal suturing. However, we believe that with the requisite skill and good support, the size of location of myoma need not be limiting factor for the procedure. So this is some samples of what we do in the karmic. We can do it in the big myoma. As you can see, this is the size of a 6 months pregnancy. As you can see, the camera is a bit stuck on the trocar, and this is some of the small samples that we can do it bleedless, and then it's very easy to taking out this myome. And then we also can do it in the multiple myomectomy. As you can see, this is the first myome on the left cornea of the uterus, and then after this one is taken out, we start doing it. The one here on the right posterior side, under the posterior corner of the uterus. And then afterward, we going up, we have another one in the anterior side. And then there's another one in here. And then it's still, if we do it right, we put the trocar position in the specific, according to the myoma size, we will not have any difficulty at all. Okay. And then let's start to the next slide. So this is the most interesting part, because in our experience, especially in Karnik, most of my fellow, when they, during the first weeks, come to my to the center, to the IGES center, they are really afraid of suturing. The problem is, my friend, if you cannot suture, then do not perform minimally invasive. It will be a danger for you and also the patient. And then we all know that the type of myome is require different technique of suturing. So most of the subserous myome, only one layer is enough. Intramural superficial will need 2 layers at least. Intramural deep, it will be needing 3 layers of sutures. And then if you open the cavity, then you need to perform at least 4 sutures. Then specifically, if the patient is an infertility patient, this type of suturing technique is really important. See? So it's not just a matter different approach between different suturing technique. It's just a matter of layers. That if you need to preserve the fertility function of the uterus, then you must suture it accordingly. And then, what about a non-scar technique? We've been talking about minimally invasive. So this is a video from my good friend John Liu. She's a urogynecologist from the Guangzhou Medical University. And then John Liu and I has been giving some speech in some of the keynotes, vaginal notes workshop in Asia. And then she teach me how to do it with a non-scar technique. So the way that you want to learn this, you must master the technique of the V-notes first. You must be able to perform the technique of doing the V-note hysterectomy. Then you can start doing this. And then if you have a urogyne by your side, it will be easier, because sometimes it's just a matter doing the colpotomy anterior or posterior before you're doing this kind of process. And then, of course, for women who doesn't need the function of fertility, we can just take out the uterus. This is some sample of the vaginal node hysterectomy. So we put the single port trocar in the vagina. So there will be no scar at all in the abdomen. And of course, regarding myomectomy, even if the myome is big, we still can do it quite easily. So as you can see, this is one big intramural myoma, and then the patient doesn't need any more fertility. So, and the patient come with pressure symptoms. So she cannot hold her pee. She's having a bit of constipation, and then she's having a bit of discomfort if she's sitting very long in one position. And then, so we decided to perform the vaginal node hysterectomy in big myome. So it is possible. So I see the sign from Dr. Eddy. I think I'm a bit running out of time. Okay, Dr. Eddy, just some couple more slides. And of course, medical management, we cannot forget. This is just a short review because we're not discussing this in the minimally invasive webinar. And then there's also another technique, that the uterine artery embolization. Actually, in Indonesia, this technique is not developing very well. But during my time in Holland for 1 year, sometimes in big myoma, my professor, we used to collaborate with the radiology in interventive division. So we perform laparoscopy myomectomy after the radiology interventive during the embolization of the uterine arteries, and it will be easier. And then what is the next step? The next step is a non-invasive surgery. So I encourage you, all of my friends, to listen to Professor Lian and Professor Aili regarding this new non-invasive surgery. So they've been doing it quite a while in China. And then Dr. Relly and I, and also Dr. Eddy, has an opportunity to go there a couple of years ago. And hopefully we can doing this in the very near future in Indonesia. So as my conclusion is, the treatment for fibroid, the management is only for the one with symptomatic. If the patient does not have any complaints, then we do not have any management. And then, of course, for infertility patient, embolization, Airlangga, IUD, and then hysterectomy also it's not an option. And then for the minimally invasive surgery should be chosen if the medical therapy is not responding. And then also we need to keep up with our knowledge that we have other options now. So from abdominal technique to classic laparoscopic to a less scar surgery, and now we are doing the no scar surgery, but all of this technique is still invasive, even though it's minimal, even though it's no scar, but it's still invasive. So during this webinar, we will be discussing more about the non-invasive surgery in fibroid management. I would like to thank you all for the kind attention. This is my hospital, the Indonesian Army Central Hospital, Gatot Subroto. This is our center collaborating with the Indonesian Gynae Endoscopy Society. And this is my team. This is one hell of a good seat. Thank you so much, everybody, for listening. So Dr. Eddy, time back at you. Thank you so much, everybody. Have a good day.
Okay, thank you very much, Dr. Nandi. What a nice presentation from you. So the second speaker will be Prof. Lian Chang from Chongqing Medical University. I will read the Professor Lian Chang CV. During that, maybe the host will be show the form that all the participants will fill the polling. We have now 519 participants, so feel free to fill the form for polling. Okay, for the participants. Okay, Prof. Lian Chang is institution from Chongqing Medical University, location China. Education, Chongqing Medical University, China, 1982 to 1987 as a medicine. Chongqing Medical University, China, 1989 to 1992 as a gastroenterology. Interesting research area, high intensity focus ultrasound for treatment of solid tumor. Representative awards, the first class of Science and Technology Progress Award of Chongqing, China, 2009. The second class of the National Science and Technology Progress Award of China, 2010. 1987 to 1995, residence of Gastroenterology Fellow, Department of Internal Medicine's Second Hospital of Chongqing Medical University. 1995 to 1998, Assistant Professor of Medicine, Chongqing Medical University. 1998 to 2002, postdoctoral fellow and postgraduate research scientist, divisions of gastroenterology, University of California at San Diego School of Medicine. 2003 to 2004, postgraduate research scientist, polymorphism research lab, University of California at San Diego. 2004 to 2013, associate professor, chief clinical center for tumor therapy, second affiliated hospital of Chongqing University of Medical Sciences. 2013, until present, professor state key laboratory of ultrasound engineering in medicines, co-founded by Chongqing and the Ministry of Science and Technology, Chongqing Key Laboratory of Ultrasound in Medicine and Engineering, College of Biomedical Engineering, Chongqing Medical University. Okay, that's the CV of Prof. Lian Chang. Maybe the host will give the summary of the polling. We have 521 participants now. Please, Dr. Edwin, show the polling for this Zoom webinar.
The polling is ongoing, Dr. Eddy.
Okay, 1 minute.
Let's wait for a minute.
Okay, thank you. Prof. Lian Chang will talk about the experience of HIFU with uterine fibroid in Chongqing. But before he present his presentations, the host will turn the video from the sponsor. But we will see the polling results first. So what about if we see the video first? The host, Edwin? You need more time for full sharing?
Namanya siapa sih?
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focus ultrasound, HIFU, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body, without causing any damage to the overlying surrounding tissues. Ultrasound-guided HIFU involves HIFU ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrates an echogenicity or grayscale changes in the ultrasound images after the sonication, which enables immediate assessment of patient's response to ablation, ensuring a safer and more controllable therapy. Imaging fusion and three-dimension digital reconstruction function provide doctors with a much clearer vision during the whole procedure. Thus, doctors can finish the treatment with an ease. Ultrasound-guided HIFU, a new option for the gynecologist to manage uterine fibroids and other gynecological benign tumors, can maximally preserving the integrity of the uterus. No surgery, no bleeding, and no anesthesia.
Okay. Have you got the result? Edwin? Cannot? Maybe if not, we can continue our Zoom or what?
Dr. Eddy, sorry, due to technical problem, we will lose the polling later.
Okay, so thank you very much. Please, Dr. Professor Lian Chang, present your presentations.
Okay, thanks, Eddy.
Thank you.
I'm ready. Did you guys see my PPT?
Yeah, we can see your protocol.
Yes. Thanks, Eddy. It's my great honor to be here and have this chance to give this presentation and to share my experience of HIFU treatment for uterine fibroids. High-intensity focused ultrasound is a non-invasive treatment modality. This slide shows how it works. This is the transducer. The ultrasound beams generated from this transducer are focused at some distance away from the surface of the transducer. During the treatment, the ultrasound beams penetrate the human body and focus at the tumor. When the temperature increased to 65 degrees, then necrosis occurred. From the monitoring image from the ultrasound, we will see the grayscale changes like this. So from MRI, we can see the temperature change of the focal region. And this is, you can see, this is the fibroid, and we can see the color changes in this area. When we see the red colors, it means the temperature already increased to 65 degrees. So please pay attention. We'll only see the grayscale, the color changes in this area. This means the temperature changes in this area. So we didn't see any changes, color changes in some other parts. It means it is precisely to, it can be used precisely to ablate the tumor. So this technique was first proposed by the scientists from the US. In 1950s, Dr. Whye used his first prototype to confirm HIFU might be used in clinic in the future. However, this technique didn't develop at a long time because there was no monitoring image at that time. So until 1980s, with the development of the diagnostic image, this technique received international attention again. And Professor Wang from Chongqing, from our university, he started this technique, this study in Chongqing Medical University. This is the transducer he used. At that time, you can see from the black box, this is the water in there, we can see the ultrasound beams from the transducer and just focus at this area. So this is the focal region. We call it acoustic focal region. So after 10 years basic research, so in 1997, Professor Wang published his results, and he further proposed, like they named this necrosis area as a biological focal region. So this is important. The AFR, acoustic focal region, is always the same in the same transducer, but the BFR, that means the biological focal region can be different. So when we use this transducer, when we use HIFU to treat the tumor, if in a safe place like this, we can use a longer time and higher power and to achieve a large necrosis area in a short time. So when we treat like this area close to the nerve, close to the blood vessels, or like when we treat the uterine fibroids, when we treat the tumor, the fibroids adjacent to the endometrium, we can use a lower power and solicate for short time to just right to ablate the fibroids without damage to the endometrium. So this is important for us in the clinic to use. So we should understand about this. So in 1997, this technique was first used to treat the patient. This was the first case in the whole wide world. So this patient was osteosarcoma. So we used this technique to, actually the treatment was very successful. In the first case, you can compare this SpEG CT, this before, here is after. So now ultrasound guided HIFU can be used to treat different type of tumors, like the liver cancer, pancreatic cancer, and bone tumors, or of course, of the uterine fibroids and adenomyosis. In 2004, FDA approved the MR-guided HIFU to be used to treat uterine fibroids. And at the first, like the first stage, first phase, they just use this like to figure out the safety. So only it was not allowed to treat the patient for a longer time. Like they only limited in 4 hours stay in there. They try to treat the patients, but the lung perfused volume was not enough. But anyway, the safety was all right. So the FDA approved this technique, and it means can be used to treat uterine fibroids. So now we have 2 types HIFU system. So one is ultrasound guided HIFU. Another one is MR guided one. So from the voting and before you raised some questions, I found like a 50-50, like some around 50% of the doctors, they don't know the difference. 92, I mean, they don't know the difference between MR guided and ultrasound guided. So I have the experience with using both. So because in our university, we have MR guided HIFU and also we have ultrasound guided HIFU. So I can compare these 2 types of system. So for MR guided HIFU, because MRI offer the best anatomical resolution, so the image is good. So also they can use this MR guided MRI to monitor the temperature at the focal region. So in comparison with MR guided HIFU, ultrasound guided HIFU can use a grayscale change to monitor the response of the HIFU treatment. But many studies already confirm that's good enough and is reliable if we use grayscale change to monitor the response of HIFU treatment. And the ultrasound guided HIFU had a lot of advantages of this because the patient was is in the same room with the doctors and the physicians or nurse. So we can communicate with the patient easily. So this system is very friendly. So the patient don't have, they are not nervous about the treatment because we are often talk to them. And also it's easy to position the patient because the ultrasound guided HIFU have the open, we don't have to, like the MR guided one, to have to move the patient in the ball. So because the ball size is very small, so the patient positioning is very difficult in MR guided HIFU. So for the room time, the ultrasound guided HIFU is much shorter. And for the treatment efficiency, ultrasound guided HIFU is much higher. So of course the cost, MR guided HIFU is much more expensive. And the most important, the ultrasound guided HIFU usually can be, it's our tool, it's a gynecologist's tool. For the MR guided one, have to be used by the radiologist. So this is simply, I mean, the difference between the two types of system. So now I'm just focused on ultrasound guided HIFU for uterine fibroids. So we started to use ultrasound guided HIFU to treat the patients with uterine fibroids in 2000. So the first case was treated in 2000. So, but between 2000 and 2005, this 5 years, it was the first phase. I mean, it's clinical studies at this time. So we didn't treat that many patients, but we just use this time to optimize our protocol. So after 5 years in 2005, we have the mature protocol, and also it confirmed the safety and efficacy. So we use this system to treat patients like in routine practice. So 2007, we started use HIFU to treat adenomyosis. I think Aili, Professor Eddy were introduced HIFU treatment for adenomyosis. Also, we already use this technique to treat some other patients, like patients with placenta accreta, increta, and procreta. And also, we use this system to treat cesarean scar pregnancy and also abdominal wall endometriosis. So for the uterine fibroids, since 2006, because after the first stage, the clinic studies, so between 2006 and 2009, in the 3 years, we use this in our hospital for like just routine practice, clinic practice. Then during this stage, all the patients, we just follow up with MRI for free because we want to see the results. Because at the first stage, the 2000 to 2005, the number was not big. But this time, we have a lot of patients, so we get this results here, like 755 patients in our center. And this baseline characteristics of these patients, you can say we had treated like the submucosal fibroids and also intramural fibroids and also some subserosal fibroids, because we want to see the indication and also optimize the indication. So for this group of patients, the lung perfused volume was 84.8%, so which is very good. So let's say if it's good enough. So you may ask, like some of the patients, you didn't achieve the 100% ablation. So actually, let's see the follow-up results. Like this is before, like the symptoms severity score, this before. You can see 3 months after that, the symptoms much significantly improved and even sustained for 3 years. It means if we achieved non-perfused volume ratio over 80%, the long-term symptoms improvement, some long-term symptom relief can be sustained. So this is the image results. This is before the volume. You can see it's around 140 centimeters cubic, and here is 3 years after that. You can much smaller. So this is the ratio, shrinkage rate. And you can see at the end of the 3 years, it's around 90%. So that's a average at 3 years. So if we achieved like the lung perfusion volume ratio over 80%, the results is good enough. So you may ask, because this is non-invasive, it's different from surgery, it's different from myomectomy. So after the treatment, like we didn't see the tumor, we didn't see the fibroids. How does this tumor go? So you can see this is a multiple uterine fibroids. This patient, like the even small one here, is a bigger one. Of course, this causes symptoms because close to the endometrium. So we treat this case, like 1 day after that, you can see the bigger one and the smaller one, even this one, very small, 1 centimeter. Then we ablated all of them. So you can see low perfusion was completely ablated. Here, 4 months after HIFU treatment, this one was gone. And also we didn't see anything here. Only here, a small part of the treated fibroids of the biggest one, but still have something there. So maybe, 2 months later, all the treated fibroids will be disappeared with just a normal uterus. So you can see the shape of the uterus was much, much better. It's very beautiful. So this is the studies from the US, like Stewart, and he performed myomectomy, and also he performed MR-guided HIFU. So this study from she published, and you can see this is lung-perfused volume. So here he said, like if the lung-perfused volume ratio reached 70%, the 2 years like interventional reinterventional rate was like 10%. It was good enough because like the myomectomy, the 2 years recurrence rate was over 10%. It means if like the HIFU treatment, if the lung perfused volume reaches 70%, then the 2 years follow-up results like is comparable with myomectomy. So this is some studies from the US and from Japan and also from Canada. And this from a NICE, like the National Institute for Health and Clinical Excellence from the UK. And you can see the lung perfused volume ratio is just likely is around 16%. The 1 year reinterventional rate was 37%, very high. So like if it's reached 55%, the 1 year reintervention rate was 10%. So the lung perfused volume ratio to achieve is very important to achieve the long-term symptom relief. So here I just want to show you some cases like HIFU for the solid operation. Yes. So that's before. Here's 1 day after it, the tumor was completely ablated. So solitary fibroids. And also we can use this to treat multiple uterine fibroids. For example, like this case, if we perform a myomectomy, the damage will be very big, but we can use it to treat, use HIFU to treat the patient in 1 session. So to achieve the symptom relief, we can also use this to treat the diffuse uterine neomyomatosis. Like this case, you can see, so no other choice. She didn't want to have the hysterectomy, then we can treat this to achieve the symptom to help the patient to achieve the symptom relief. So just 1 session, the symptom relieved. So for the pregnancy outcome after HIFU treatment, we already have many papers. The result shows no complication, was good enough for this one. I just want to show you 2 cases like this multiple uterine fibroids. If we perform myomectomy, the damage to the the uterine wall will be very large. Then we treat it with HIFU. Multiple uterine fibroids, we ablate it, but low damage to the normal smooth muscle of the uterus. So 1 month after that, the patient conceive and develop baby at terms. And also this one, the same thing. Some mucosal fibroids we did, and also deliver baby. And also, like I said, for the submucosal fibroids, if the patient wants to go to IVF, we can ablate the fibroids precisely without damage to the endometrium. Like here, the fibroids was completely ablated, no damage to the endometrium. So that's all I want to share with you guys. Thank you very much. Eddy? Thanks.
Unmute dulu, Dr. Eddy. Unmute.
Okay, thank you, Professor Lian Chang, for your nice presentations. We come to the discussions. Dr. Lee will accompany me for the discussions as a panelist. Dr. Keen Whye is a consultant obstetrician gynecologist at Gleneages Medical Center with special interest in HIFU, hysteroscopy, laparoscopy, and vaginal rejuvenation. Dr. Lee has done many international lecture and preceptor many endoscopic workshops in Malaysia, Indonesia, Vietnam, Taiwan, Korea, India, and Myanmar. He is a founder member of the Asia Pacific Associations of Gynecology Endoscopists, APAGS. In 1996, he received an Achievement of the Year award from HQ, Army Medical Service Military Award. In 2003, Dr. Lee was awarded the prestigious Benjamin Henry Shears Gold Medal by Obstetrics and Gynecology Society of Singapore. Okay, maybe there is any questions from the attendees. You can raise your hand or type your questions to the chat box.
Dr. Eddy,
as a panelist, comments?
Eddy,
Yep.
can I show a slide to explain certain terms to everybody? Can you help me show the slide? Can I share a slide?
Host, please share.
Can I share a slide?
As a co-host, Dr. Lee.
Sure. First, I want to thank, on behalf of APAGE, I want to thank Indonesia that actually was officially the first country to accept HIFU as a topic of discussion and lecture in 2018. And that was due to the effort of organizing chair, Dr. Relly. Okay, I just want to show this slide to everybody just to explain, because I'm also a newcomer to this technology. Number one, HIFU, HAIFU, is the company or the company that actually supports the University of Chongqing Haifu Hospital. The term HIFU without A is the technology, and you may hear the term FUS, which stands for Focused Ultrasound Surgery. This is usually used by America, Europe, and some other countries. And then in China, they want to distinguish themselves from all the other FUS, especially distinguish themselves from the MRI guided HIFU. They've added FUAS to indicate that it is a focused ultrasound ablation surgery, because the Chongqing HIFU has the power to ablate. The energy level is much higher than the MRI guided HIFU. So that's my simple slide I want to share with everybody. Thank you.
Thank you, Dr. Lee. Is there any comments or questions from the attendees?
Maybe Dr. Winarno Sarkawi Dr. Eddy want to ask the speaker.
Please, Dr. Winarno. Dr. Winarno, please. Where is Dr. Winarno?
Dr. Winarno, we cannot hear your sound.
Okay, this is questions from Professor Aili to my questions to Dr. Ichnandy. We usually choose the treatment of myoma to be very individualized. We found that no matter laparoscopically or hysteroscopically and through abdominally, the dimer increased after operation. We could screen for, pulmonary embolism and venous thrombosis. The dimer increased more than 3 times the normal value. What is your experience? Dr. Nandi.
Yes, doctor. Hello.
Ya, silakan.
Hi, Prof. Aili. How are you? So, regarding your question is actually in our experience, it depends on your pre-operation preparation, and then we already analyze each patient before going into the operation room, and then if we have anything abnormal, we will collaborating with the internal and hematologic division to stabilizing it. Then so we do not have any complication after our operation. That is my experience. Maybe Dr. Eddy, Dr. Relly will add some more about this. Thank you.
Thank you so much for your answer. But my question is, will you do the check after operation? But many years ago, we also do like your side, evaluate before operation. But recently, we found that the dimer can increase after operation. We check every patient's dimer after operation, including HIFU. So we compare HIFU laparoscopically, hysteroscopically, and abdominally for 4 types. But we found the dimer usually increased after, especially abdominally for multiple myoma. The dimer can increase. So did you usually do this kind of screen after surgery? But before operation, we evaluate very well also. Everything is normal. But after operation, the dimer will change 80% patient.
Thank you, Prof. Unfortunately, we do not have that kind of data in Indonesia because we're not used to check every dimer after post-operation. We only do the reanalyzing in a very specific patient that has a risk factor.
Okay, thank you so much.
That's our experience in Jakarta. Maybe Dr. Relly in Surabaya would like to add something, please.
Yeah. Firstly, thank you, Prof. Aili, for your question. In my experience, we don't have any experience for the thromboemboli after the surgery. So that's why to check the dimer routinely after the surgery, we don't have any experience for that.
Thank you.
Because
the
cost for the check the dimer is not so cheap. It take costly in our hospital.
I see.
So that's not routinely.
Thank you.
Yes.
Okay.
Hello.
Yeah.
I'm Dr. Mina. No, I'm sorry. Moderator. Hello.
Yeah, please.
Hello.
Okay.
Yeah. Sorry. I want to ask a question to Dr. Yeah. Thank you, moderator. I want to ask one question to Dr. Nandi. Very nice presentation about fibroid. If you meet one woman with subfertile for years, marriage, and get pregnancy spontaneously, but she underwent minimal spontaneous bleeding for about 1 month and she had also 3 or 4 fibroids about 4 centimeters. Hello? Hello?
Yes, doctor.
Yes, okay.
So,
Yes.
Yes, we can hear you.
my question is to Dr. Nandi.
Yes.
If it's important to remove all the 3 myomas about 4 centimeters each other,
In this
do you use
patient that already
laparoscopic
have a
enucleation? No.
we don't have the device in here, doctor.
No. So,
no, we don't have the generator for that. But when I was in Holland, I performed some laparoscopic ablation together with my professor.
Or laparotomy, which is better? Which is better?
No,
because we want to preserve the pregnancy up to full term pregnancy, because it's very one to pregnancy, and this is the first pregnancy after 4 years marriage, so fertile case. It is dangerous when you did laparoscopic in pregnant women, especially in the first trimester of pregnancy. Thank you.
Okay. Actually, I do not have any experience in laparoscopic myomectomy on pregnant women. The one that I do is laparoscopy cystectomy in pregnant women, doctor. And then, as far as I'm concerned, in my professor center in Holland, usually they do not perform any laparoscopic myomectomy, only if the myome is getting bigger and then give a bulk symptoms to the pregnancy itself, but the myome mostly subserosal, then we perform a single port laparoscopic to take out the myome, and then with the single port you can easily take out the myome and then morcelizing it by your hands. But that's in pregnant women only in subserosal. But that's only when I was back in Holland. Back in Jakarta, I never performed laparoscopy myomectomy in a pregnant women, doctor. Maybe other panelists have some experience doing laparoscopic myomectomy.
Sorry. I want give you just information. I myself did undergo this patient. She is actually my private patient. I myself underwent also laparoscopic technique with Professor Sam in 1993 in Kiel, Germany.
Yes.
But for this patient, I didn't choose this method because I think there's a pregnancy. So after 4 months, there is a symptom and of intrauterine growth retardation. So I decided for the patient and her husband, I had to do laparotomic enucleation of all myoma. The 3 myomas, it's about 4 centimeters because it's disturbing, not only for bleeding, but also IUGR for small baby. And after operation, I give also many kinds of drugs to continue the pregnancy. And after 9 months, because of the malpresentation, I did cesarean section, and the baby is about 3 kilograms, and the mother also in good condition. But after 3 years, she come again. Well, even though she is very rare to check in my private clinic, she has also second spontaneous pregnancy, but a new myoma bigger than formerly. It's about 5 to 6 centimeters because no disturbance at the fundus, no disturbance. So I can continue the second pregnancy up to the full-term baby, and then did second laparotomy, and after cesarean section, I did also permanent contraceptive after giving many explanation for the mother and the husband. Thank you. Thank you very much.
Okay, thank you, Dr. Winarno. Maybe
Please your comment.
Dr. Lee, any comments from you regarding to Dr. Winarno's questions? Dr. Lee?
Okay, moment. Okay, can you hear me?
Yeah, okay.
Okay,
We hear
sure.
you.
Generally speaking, in obstetrics and with fibroids, we normally do not operate for fear of the side effects of the surgery itself, anesthesia. But if you have a very good reason to remove the fibroid, normally I do it in the second trimester, and definitely not laparoscopy, because if you do the laparoscopy, you have to waste time stitching and waste time doing the morcellation. I think what the professors we now know say is correct. Just go on to the laparotomy, get the fibroids out, stitch properly again the layers, and then hope for the best. I think I would have done laparotomy.
Okay, thank you. Nice questions. And Dr. Cahya Sanggara, who has the authority or competence to perform ablation with HIFU? Any comments from the two speakers or panelists? Who has the authority or competence to perform ablations with HIFU?
I think
when I was in Chongqing with Dr. Relly, it was the gynecologist who performed the ablation with HIFU. Right, Dr. Relly?
Yeah, it's agree. So as already the Prof. Chang explanation with his presentation, that the advantage of the ultrasound HIFU is done by gynecologists, not from another subspecialty like radiologists, like MRI, HIFU, isn't it? Isn't it right, Prof. Chang? How about in China? Who is operate the HIFU?
Yeah, like the gynecologists. They perform.
Maybe the question is which gynecologist can perform, which competence? Yeah, which gynecologist?
I think it's all gynecologists. General gynecologists can do it.
Yeah.
No, I mean
general
gynecologists already know or educations.
I think all general gynecologists can do it, but firstly they have to take training first during the HIFU, because it's very it's very complicated procedure to do.
Yeah, I think for the next this is technique will be the IGES and SpOG will arrange has the authority to get a rule about this technique. Look like robotic. So because today we have an KKI and SpOG, I think we need to learn about this treatment and then make the guiding for gynecologists to do this.
Yeah. Okay, I agree with you, Dr. Nadir. Maybe before we make a decision who is competent to doing the HIFU, maybe we can learn from another country like Singapore or like China, who is the person who did the HIFU. Maybe probably from Singapore can explain.
Can I speak?
Yeah.
Okay, sure. I think you must understand, I'm in private practice now. So my concept and thinking, it's very practical. First and foremost, the question of who can use the HIFU machines. Actually, any medical officer who is trained in HIFU can do it, because a lot of the trainers that is training me from Chongqing, they are just medical officer level. That means the moment they pass out as a doctor, they go straight into Chongqing Haifu University for training. Now, but again, for us, like all of us here in gynecology, yes, almost any gynecology can perform HIFU, especially if you have done ultrasound in your practice, because you have to do a lot of ultrasound monitoring during HIFU. So if you know, let's say obstetric ultrasound, whereby you monitor movements of the babies and all this, this will be an advantage to do ultrasound guided real-time HIFU. Okay. Now, I noticed there's a question on how big the fibroid, how small the fibroid, and what can you do? Generally speaking, if it's an intramural fibroid that it's smaller than 3 centimeters, maybe we can wait. But anything 3 centimeters and above, even the laparoscopic surgeons, especially those in infertility, IVF group, will say that 3 centimeters intramural may be a problem that causes infertility after a certain period of time. So for those who are thinking of doing HIFU, I would say if they've tried to get pregnant and you can't, then I would say, yes, HIFU is the way to go. Now, for a patient who is, let's say, 45 years old, 50 years old, and having menorrhagia, where fertility is not a priority, yes, you can do ablation with HIFU. And I think Professor Zhang Lian and his team in China is trying to write a paper on ablation, endometrial ablation to treat menorrhagia or heavy menses in patients who do not need fertility. Okay, coming back to a more practical point of view, you can have 2 patients with a 6 centimeter fibroid, another one with a 6 centimeter fibroid. Patient A with 6 centimeter fibroid, you can treat it and everything can be done within 2 hours. But another patient with a 6 centimeter fibroid who is very vascular, supplied by a lot of blood vessels, that may take more time. And if you have multiple fibroids, then the timing is even more. So because I'm in private practice, I am starting this sort of understanding with my colleagues, because that machine can be used by all the gynecologists trained in HIFU. So like all surgeries, say for example, how long you take to do a Caesar, you may say you may book for 1 hour. How long you do a simple myomectomy, you may book for 2 hours. But in HIFU, sometimes it's very unpredictable. It can be as short as the same 6 centimeters fibroid can be as short as 1 hour, or can be as long as 3 hours. So we set up this understanding that we try not to do anything more than 2 hours, because the next doctor is coming in, the next team is coming in. So if you have multiple fibroids, or fibroids is 10 to 12 centimeters, I now tell the patient that I will do up to probably about 2 hours. Then we have to do the rest of the fibroid or the rest of the fibroids about 4 to 6 months later. This is to be fair to the surgeon that's coming after me, because they will bring their own anesthetists, they will bring their own nurses to come in. So again, it's a very practical approach in HIFU and fibroids in a private practice setting, because the machine is used by so many parties. It's different if you are in a university and you have the machine and only you are working on it the whole day. So that's my 2 cents worth. Are there any more questions? If there are no questions, I would like to show a slide on my opinion on fibroids and the classification in relation to HIFU. Dr. Eddy, is it okay I show the slides on, it will take another 5-10 minutes.
5 minutes, okay, Dr. Lee? Okay, 5 minutes.
I'll share the slide.
Okay, thank you.
Now I can always jump and skip this one. No, skip next one. I need to share the slide. It's not moving. I don't know. Okay, sure. Try again. Okay. Okay, can you see the slide?
Yeah.
Oh, no, not this one. Next one. Okay, this is a slide which is very familiar to everybody, and everybody uses this to show in all the fibroid talks. Now, what I'm going to tell you is something, I think when you're doing HIFU, is something which is more simplified. For example, for 0, 1, and 2, I think most of us who are experienced will approach it through a hysteroscope. Now, 2, 3, 4, 5, all this intramural, to a person, or even 6, to a person doing HIFU, is just the group of intramural fibroids. So this classification for us has to be simplified. And I hope Professor Zhang Lian, who is the authority, can do something to simplify. I always said, this is experience-based medicine. It's different from evidence-based medicine. The question we ask when we have a fibroid is whether you can treat or you cannot treat. If you can treat, how to treat. This is again the FIGO classification, but I want to simplify it by using just 3 examples below. This is definitely something treatable with HIFU. This one is probably best used with hysteroscopy. This one, which is pedunculated with a stalk, I would advise not to treat with HIFU, because once you treat with HIFU, this one will float in the abdominal cavity and you have to remove it if it's become symptomatic. So it is my proposal is simplify things for everybody, not just to do a classification so that you can put a name on it. I think we have to be very practical about things. This is submucous fibroid. This belongs to a colleague, Dr. Wahidin. After doing the fibroid from, which is actually a classification 2, just dropped out after a few months. This is my patient after doing fibroid, which is again intramural between 2 to 3, and the body actually decides how to get rid of the fibroid. So the uterus can decide to absorb the fibroid or expel the fibroid. So this is actually the patient's a nurse. When she found this, she took a picture and showed to me. The other one was very interesting. Another patient of mine, she is probably the smartest patient. She actually put a ruler against the fibroid to tell me her fibroid dropped out. Now, this is a patient of mine, which I did a hysteroscope in 2019 in July, before I do the HIFU. In the cavity, there's no fibroid, which is actually 0, 1, or even 2. Maybe you can see something from the top. Maybe you see, yeah, the beginning of type 2. 9 months later, the fibroid decides to come down. That means from here, the fibroid presents down. That means from something intramural, it becomes submucous, and this can happen. So you can see the fibroid coming down here, fibroid coming down here, in the same patient after 9 months of HIFU, and she started bleeding. That's why she came back to see me. And Just this was done only 2 weeks ago. This is the fibroid that's coming down. I'm cutting off the base of the fibroid from the anterior wall of the uterine cavity with the usual resection, and this is after resection done. So my point is that that you can have a myoma which is type 3, but it can present as type 2 and type 1 after HIFU. Now, my point is, will HIFU replace open and minimally invasive surgery? My answer is no. I think that's all I want to say about HIFU and fibroids. Thank you very much.
Okay, thank you. We come to the end of the discussions. We'll move the session through. If there is any questions from the attendees or participants, you can email the speakers privately. Okay, thank you. Okay, the second sessions will be two speakers, Dr. Relly and Prof. Aili. Maybe from the host will show the video from the sponsor.
That sometimes if things are bloody or tissue is very fatty, the use of a split screen window can be very helpful. As you can see in the upper left corner, there's a black and white picture, and there's a very strong white signal. And if a signal is that strong, it most likely is to be a sentinel behind. So when we see that, we can look for in the overlay picture. And if things aren't clear what kind of tissue it is, we have the normal picture on the right side. Not all devices have the opportunity for split screen. I think it takes a lot of calculating power for the computer. But I kind of like this feature. It is very useful at times when things are not so clear. Most important is, though, in the black and white picture, if, for example, we spilled ICG and everything is a little green, in the black and white picture, one can clearly see how strong the signal is, and if it is just little dirt or if it's real fluorescence.
Okay, thank you. Dr. Relly January Primariawan, SpOG consultant. Birth in Surabaya, January 28th. Chairman Fertility Endocrinology Reproduction Divisions, Department of OBGYN, Dr. Soetomo General Hospital. Chairman of Indonesian Permanent Contraception Organization, Surabaya Branch. Endoscopy Task Force of Indonesian Obstetric and Gynecology Associations. Chairman of 19th EPH Congress 2018 in Surabaya. Vice President of IGES, Indonesian Gynaecology Endoscopy Society, 2018 to 2022. Formal education, 1986 to 1992. General Practitioner of Medical School of Airlangga University, Surabaya, 1997 to 2001. Obstetrician and Gynecology of Medical School of Airlangga University, Surabaya, July 5th, 2010. Consultant of Fertility Endocrinology Reproduction. Non-formal education, August 30 to November 30, 2004. The Diploma in Advanced Endoscopic Surgery, Laparoscopic and Hysteroscopic at the Kiel School of Gynecology Endoscopy, University Hospital Schleswig-Holstein, Kiel, Germany. Okay, Dr. Relly, the time is yours now. Adenomyosis and infertility treatment. Okay, thank you.
Thank you, Dr. Eddy, for your nice introduction. May I share my screen, my slide? Okay, can you see my slide?
Yeah, okay, very good. Clear.
Okay. Okay, first of all, I would thank to President of IGES, Dr. Nadir, has ordered me to talk in this Zoom meeting, seminar. Yeah, it's very nice meeting because we have can share our knowledge, sharing our experience from Professor Zhang and Professor Aili from China. And before the Professor Aili talk about adenomyosis and HIFU deeply, I will talk about adenomyosis and infertility treatment. Okay, I have already introduced by Dr. Eddy. So my talk today is about clinical diagnosis of adenomyosis and infertility, and how about for the surgical technique for adenomyosis, and my conclusion. Okay, good. As we know that adenomyosis is benign disease, you know, everyone know about that. And for definition, adenomyosis, which is endometrial glands and stroma of endometrium inside the myometrium. This is the definition of adenomyosis. Adenomyosis is a clinical challenge even for diagnosis and the treatment. Before the last decade of from now, which is the imaging of the ultrasound and MRI is not so good compared with now. Is it very difficult to diagnose adenomyosis before the surgery? Yeah. We just only found the diagnosis of adenomyosis after the surgery, after we have to take out the fibroid, take out the uterus after the hysterectomy, or after we have did the biopsy inside the uterus. So this is still our challenge to perform diagnosis and treatment for adenomyosis. So that's why the true incidence of adenomyosis is still unknown due to the lack of the standardized definition and diagnostic criteria. We can see here so many papers that show us about the prevalence of adenomyosis. Is so many difference among of the expertise, because there's no standardized of the criteria for diagnosis, and there is no standardized for the how to diagnosis exactly. Around 21.8% adenomyosis is commonly caused together with endometriosis, undergoing a surgery of endometriosis. And adenomyosis is association with the fertility women, and also adenomyosis can increasing with the increasing age. And also adenomyosis has a dysmenorrhea intensity with the pain. And also adenomyosis is association with the deep infiltrating endometriosis. And adenomyosis also, a patient came to us with the abnormal uterine bleeding and also with the uterine enlargement with adenomyosis. So many theory to explanation for the adenomyosis, but until now they are still remain debatable. Which theory is fit for the cause of the adenomyosis? Theory of endometrium migration, transformation theory. There are so many theory there because some destruction of the endometrial line. So that's why the endometrium can migration from the endometrium cavity to the myometrium. So there is another theory, metaplasia theory, Molliron treatment theory, reaction, TR, tissue injury and repair theory. So many theory about that. But a lot of expertise believe that the cause of adenomyosis is One is the iatrogenic trauma, because the trauma on the endometrium, that's why can make endometrialization came to the myometrium and can make adenomyosis lesion. And also the adenomyosis has influenced by estrogen with estrogen receptor beta. So with this receptor can provide to activate inflammation, pro-inflammation cytokine from macrophage, and then after that, so many cytokine can has produced by macrophage and to stimulate adenomyosis, and which is adenomyosis can survive. This is the pathogens of adenomyosis. So how about for the clinical diagnosis of adenomyosis? As we know, adenomyosis is benign, but the patient with the enlargement of the uterus and getting pain, and also with the vaginal bleeding, even for the excessive bleeding. So it could be disturbing of the quality of life of this woman. So that's why adenomyosis is not a danger disease, but the adenomyosis can reduce the quality of life, especially if the patient has an infertility problem. But until now, there is remain debatable. Is it the adenomyosis is likely can disturb the infertility? Is still not conclusion about that up to now. As I told before, so many years, the diagnosis of adenomyosis is based on the histopathologic exam on hysterectomy specimen after the surgery. But now, with the improvement of the tools, the improvement of the imaging of ultrasound and MRI, so we can diagnose adenomyosis, with the minimally invasive tool, how to making diagnosis adenomyosis with more reliable. So with the two tools, the specificity and sensitivity is good. It's can 72 and 77% for sensitivity for ultrasound and MRI, and for the specificity can 81 until 89%. But another study maybe can maybe more higher than this study about the sensitivity and sensitivity for the ultrasound and MRI to diagnose of the adenomyosis. In daily practice, ultrasounds, as Dr. Lee Keen said, that if the gynecologist has using ultrasound in daily practice, therefore ultrasound is the first line diagnosis to investigation of adenomyosis. With the ultrasound, we can find the characteristics of adenomyosis with the heterogeneity. Some is increasing the echogenicity, some is decreasing echogenicity, and also there's a lacune in or myometrial cyst inside the adenomyosis. So many characteristics of ultrasound about the adenomyosis. More elliptical shape lesion and poorly defined borders. This is one of the characteristic of the adenomyosis. Is a difference with the fibroid. The fibroid with the border is more clear enough, but for the adenomyosis is very purely for defined borders of adenomyosis. And also from the ultrasound, with the good imaging of the ultrasound, we can show that there is not clear enough for the border of endometrial line and the myometrium. So there is not clear enough the border of the endometrium and the myometrium on the adenomyosis. This is the characteristic, one of the characteristic of the adenomyosis. And also asymmetric thickening of the myometrium, and also from Doppler, there's a blood vessel follow their normal vertical course of the myometrium areas. It's different with fibroid if we perform Doppler. From fibroid, we found that blood vessel is located around the fibroid peripherally. Here is from the ultrasound, we can hear there is adenomyosis in myometrium. There's the borders, we cannot see it clearly enough. And also for the border of endometrium and the myometrium, or the junctional zone has already destruction, we can see clearly. So this is the sign of the adenomyosis. And also the asymmetrical shape of the fibroid, of the uterus, is one of the sign of the adenomyosis. And from the Doppler, we can see here the vascularity of the adenomyosis is in the middle of the mass of the adenomyosis, and also there is some cystic in myometrium. So there is one of the adenomyosis sign of from ultrasound. How about from the MRI? MRI, we can see there is the thickening of the junctional zone more than 12 mm, and also the irregular of junctional zone thickness is. We can see if the junctional zone is different thickness. So if the difference is more than 5 millimeter between maximal and minimal thickness, there is MRI will be show that there is adenomyosis. And also from MRI, there is a very purely defined area with low signal intensity in myometrium and T2. And also on the island of the endometrial tissue, identified the punctate focus signal intensity is in T1. So from MRI, we can make more specific, more accuracy to diagnosis adenomyosis compared with the ultrasound. We can see here there is junctional zone is more than 12 mm. We can suggest that there is adenomyosis inside the uterus, and also we can hear the border is not clear, and also there is junctional zone is so many difference. We can measure the long distance of the junctional zone and the shorter distance. If the difference of both of them is more than 5 mm, we can conclusion that this adenomyosis inside the uterus. And how about for the adenomyosis and infertility? Until now, there is no definite proof association adenomyosis and infertility, because the incidence of adenomyosis also increased in a multiplicity of women after 4th and 5th decade of the life. So we found adenomyosis in more frequent in patients after surgery hysterectomy with multiparous women and more than 40 years old. So that's why we can conclusion that adenomyosis, it should be infertility, but until now there is no conclusion about that. But there's some many mechanisms which adenomyosis can reduce the fertility. Firstly, with adenomyosis can impairment or can reduce the sperm transportation, because from the uterine contractility after with the adenomyosis is make impairing rapid and sustained directed sperm transportation. So that's why with the adenomyosis can reduce the fertility. And another proposed that adenomyosis can reduce the fertility because the adenomyosis making reduce for the embryo implantation. It means the embryo implantation rate for adenomyosis is more lower than a normal patient. Why is it happen? Because with the adenomyosis, so many vascularization the adenomyosis and making increasing in secretory phase, and also the arranging endometrial milieu. That's why can make negatively affecting in implantation. And also during in adenomyosis can also alteration of expression of profile cytokine and growth factor in endometrium and endometriosis. That's one of the cause why adenomyosis can reduce for the implantation rate. So another proposal that increasing expression of cytochrome P450 and also increase in aromatic activity and increased expression of estrogen receptor alpha while secretory phase, and also over expression of estrogen receptor. And also this is one of the decreasing expression of cell adhesion molecule such integrins that can reduce for the receptivity of endometrium for implantation. Here from Versilini, from his study, from review, systematic review and meta-analysis, they from the study conclusion that adenomyosis are making worse for IVF outcome for the pregnancy, for the clinical pregnancy. That's why the adenomyosis can disturbing for the fertility of the patient. And also not only the pregnancy rate, but the miscarriage after with the adenomyosis is more higher. So that's why adenomyosis is getting worse for the pregnant, because the miscarriage rates is more higher than a normal patient. And another meta-analysis systematic review, there's only two studies from systematic review from Tulandi. There's two studies. The conclusion that focal adenomyosis is more higher for the pregnancy compared with the diffuse adenomyosis from IVF outcome for the patient. And also adenomyosis has a risk of preterm labor delivery. This is from study from Taiwan that's said from the odds ratio for the adenomyosis to get the preterm labor is 1.83. So in the adenomyosis getting higher to get the preterm delivery.
Excuse me, 3 minutes remain, Dr.
Okay.
Relly.
Okay. It's also another study said that adenomyosis has increasing for the preterm delivery. So how about for the surgical technique of adenomyosis? Until now, there's invasive, can open, or it's a minimal invasive surgery, laparoscopy, hysteroscopy, or maybe no scar surgery with nodes surgery, or maybe we can put the non-invasive surgery for the adenomyosis in the patient with HIFU. So for invasive, we have a conservative surgical treatment. We can perform adenomyomectomy with complete excision or maybe partial adenomyomectomy. There is a classical technique for the adenomyectomy with overlapping flaps. There is a SADA procedure with triple flap techniques for the adenomyectomy. And from study, they said that only few good quality studies for these procedures, but from this study, the surgery, even only partial excision, that the reduction of dysmenorrhea can reduce until 82, 81, and 84% to reduce for the dysmenorrhea pain on the patient. In terms of menorrhagia, also reduce, but in the conception rate, there is no statistically significant difference between partial excision or complete excision. So that's why surgery up till now, the result is not satisfied for us for the adenomyosis. This is analysis systematic review. Meta-analysis from Tolandi also said there is assess that the study that spontaneous pregnancy is getting higher if the surgery after the surgery and with the gender agonist, but the study is only two. We cannot make conclusion that surgery can improve the infertility outcome in adenomyosis. And also non-invasive surgery, HIFU, maybe later on from Aili will be explanation her experiences of non-adenomyosis on HIFU. And there is some picture of the HIFU. This is MRI guided HIFU, and it is just the ultrasound guided HIFU. So my conclusion that adenomyosis may cause fertility outcome decreasing by decreasing impairment of sperm transportation and decreasing for the implantation rate. But until now, there is not clear enough that surgical intervention for adenomyosis could improve the fertility outcome. And we hope that new modality treatment for adenomyosis can improve the fertility outcome. Thank you for your kind attention. And we back to Dr. Eddy as moderator. Thank you.
Okay, thank you very much, Dr. Relly, for the nice presentations. I will invite Prof. Aixingzi Aili for the HIFU experience in Shanghai First Maternity and Infant Hospital. Professor Aixingzi Aili is a supervisor of master and doctoral students, head of the HIFU unit, the first affiliated maternal and infant hospital of Tongji University, deputy director of endometriosis group under the Shanghai Medical Associations of OBGYN, member of the minimal invasive and non-invasive medicines committee under Chinese Medical Doctor Associations, praised as the most warm-hearted doctor by the China Medical Forum, honored as the woman pace-setter of Pudong district in the year of 2013 and 2014, praised as one of the top 10 angels of maternal and infant care in the year of 2016 and 2017. Okay, Prof. Aixingzi Aili, the time is yours now.
Thank you for your kind introduction. So firstly, I am so glad to be here to share our experience. And I thank for Dr. Lee's recommendation, and I thanks for the invitation from Professor Relly. At the time, we are all in the very hard situation, so we call it in the post-viral area. So all were in one village. So I'm in Shanghai now. This is our hospital, and our hospital usually very focused on the scientific research, and we have many important centers. Up to now in Shanghai, our center's cases ranked to top 1. So also we have some experience. So our hospital will build another new building very soon. So, and I hope we can have a new area, because the center up to now, we are in the 7th floor, a little bit smaller. So our hospital began to build a new building at the end of this year. So I hope our HIFU center can continue to expand it. We have applied for 800 square meter space. Okay, now it's very clear. Thank you. Maybe it can become the largest HIFU center in China. In this way, we have enough space and ability to accept visiting whatever from inside of China or outside friends. So usually every month we have visitors from different hospitals. So our team helps to build a world-class HIFU team. So this way will take at least 10 years or more, I feel. So at the person in charge of opening. So I am the first doctors to respond for HIFU in our hospital. I will try my best to accumulate profound experience. So I will introduce our experience here. So the history we already know very well. This is a world picture. So we can see the Singapore Dr. Lee. He is very good for Team Gamma. So the friends beside me said the people can't hear my voice. Dr. Relly, thank you. Can you hear my voice?
Yes.
We can hear you, please.
You.
Your voice clearly.
The small friend, the little friend beside me said some people can't hear. So Singapore, let me remind Dr. Lee. He is my teacher, also the brother, also karaoke friends. He sings karaoke very well. So this is a very magnificent center. We can see very amazing center. So the Chongqing HIFU can connect everywhere, like heart to heart. So our center also connects with them every day. So we will see here the beautiful light, just like blooming fireworks. So I hope in the future we can see some fireworks in Indonesia.
Hopefully.
So this is a mechanism. This is already Zhang Lian professor mentioned. So this is our experience. The first is skin preparation. This procedure performed by nurse. So here we can see that this is the first step for patients, very easy. And the second step is evaluate the lesion and the vascular supply of lesions. This is through MRI. I usually compare MRI to the GPS guide when we driving. So very important thing, we evaluate correctly the size of the lesion. And the third step, we through ultrasound guide do hypotherapy. We will see here very clearly the blood is a very important organ to protect the bowel. So we will find the posterior lesion here, adenomyosis, and then we will see the white color grayscale change inside of the lesion. So that is usually happened if you have a lucky hand. Many colleagues call my fingers is golden fingers and always mention I have lucky hand, inshallah, and I hope I can keep these lucky hands. And this is the first second best. We can see the beautiful white color here. So it means HIFU performing the very good effectiveness results. So this is our center. So we will see the patient lie on the bed, and this is our anesthesia. She can look after the patient very well. So we can see the performing table. There are exactly 5 screens. So we should have a very good eye. So in our center, the common case we perform, the first choice is adenomyosis. Second is myoma. Third is cesarean scar pregnancy. And another one is adenomyosis abdominal. I found some very good people for uterine fibroids. So we will see here the huge cases. So based on this observation, so we will find the HIFU is very good choice for the fibroid. This is for adenomyosis, 2 years follow-up results. So it's also very good. And these people from Professor Zhang Lian, high intensity focus on ultrasound ablation for uterine fibroid. And we will find a very good prospective study. So the conclusion is HIFU caused substantially less mobility than surgery with similar lifetime cure. Despite the group baseline difference and the backup finding, this finding supports the need for randomized control RCT. So we have a clinical RCT center now in our hospital. We are doing some MRI and the HIFU study. HIFU treatment for fibroids are either experimental design that facilitate the RCT control. So this is a very good paper for C-section pregnancy. So we will see also can very useful through HIFU. This is also the C-section scar pregnancy. So this is all placenta area. So also HIFU can play a very good role. So HIFU treatment followed by hysteroscopic resection is safe and effective to treating patients with PA. So this is for the abdominal wall adenomyosis. We have cases later will show. This is based on this result. It appears that either HIFU or surgery is safe and effective in treating patients with ABE in short term compared with surgery. HIFU treatment for ABE has advantage or shorter hospital stay. So we begin HIFU from 2015, nearly 5 years. In whole China, we are in the third level here. So this is cases from 2050, end of 2050 up to now. We are already nearly to 2,000 cases, 1,400. We will see the common cases we choose for HIFU is adenomyosis and myoma. And we also published 2 papers. The first one is for adenomyosis. We combine the 3 steps. The first is HIFU instead of surgery. So as a sophisticated surgeon of the long-term gynecology, we will find that actually the adenomyomectomy to some extent is not have very good results, easily recurrence. So HIFU can instead of surgery for adenomyosis. The second step is GnRHA or other medicine. And the third is Mirena. This is the 3 steps for adenomyosis. We already had a very good result. The second paper we published just recently, high intensity focused ultrasound treatment for diffuse uterine leiomyoma, a feasibility study. So the first is for 3 steps. Except the GnRHA, we usually use the dinogestrone and the mifepristone and also the gospel acetate. This medicine from plant. In the many years ago, it was found from the professor from in outside. I forgot which country, and for use infertility for male. So the third step is Mirena. So as we know, the Mirena can play a very important role. So this is the uterine cavity that put Mirena 13 years. So the pathology result, we can see the not any hyperplasia or any change. But we found the Mirena had some relation with breast cancer or some other breast disease. So for the leiomyoma, multiple leiomyoma, so we found that they are not a very good surgery. So this is a very important picture from our study. So for A, we will see posterior adenomyosis, and 1 day after HIFU, we will see the ablation nearly 80%. And after 18 days, we can show the beautiful shape of the uterus. So this is a VAS score, and volume score compare before operation and after operation, and the hemoglobin and uterine volume we can see shrink gradually. And also the very important marker CA125 can decrease very well. So the conclusion for our first study, we will find the lowest of the risk of hysterectomy compare. So second, HIFU is safe and effective and efficient. It can improve the patient's quality of life. Though mostly the patient come to our center, they wouldn't like accept hysterectomy. They want to keep their uterus. The second study is for the diffusion uterine leiomyoma. This kind of disease actually except hysterectomy, no other choice before. So up to now, we find from paper nearly 61 cases. In our center, we did 8 cases. In this study, we successfully treated with HIFU. Our patients were young. The average age is 32. All the patients presented with menorrhagia. The important symptom is menorrhagia, and one patient also compare of dysmenorrhea. So 6 patients previously underwent hysteromyomectomy before. So we met one patient already do 5 times myomectomy, and one patient received transabdominal myomectomy twice. So 5 of them were multiparole. All of these patients had a great desire to preserve their uterus. So as shown in the table 2 here, the uterine size was shrink the very large, approximately 20 gestational weeks, and the mean uterine volume is here, so very large one. 5 patients had never given birth before, and all 8 patients wish to remain. They want to have child later. All of the patients had anemia, and the mean pre-treatment serum hemoglobin is lower when they were admitted to the hospital. So one patient had changed in CA125. As we know, in the myoma, the CA125 seldom have any change. So we do the HIFU here. So ablation risk is lower than average like others myoma or adenomyosis. So this diffusion leiomyoma is very hard to treat. Here we can see the first picture. So many small myoma inside of the uterine cavity, like Dr. Lee mentioned, actually submucous myoma is good for hysteroscopically treatment, and peduncularly subserous myoma is good for laparoscopically. But this kind of types everywhere we can see the myoma. And here, so we can see the different signals. This is after treatment. We can see the whole size of the uterus shrink very well. So before and after HIFU, we can see the uterine volume and also the menstruation and hemoglobin all change very well. So based on our result, HIFU is suitable for young patients with DOL and may lead normal menstruation and improve quality of life. The HIFU treatment also safe and effective. This is the co-operative paper with Professor Zhang Lian, and this is adenomyosis type. As we know in the textbook or other material, we seldom see the very specific and suitable types for classification for adenomyosis. So we, based on the textbook, divide into 2 types, focal and diffuse. And then we divided A, 2, B, and C. So A means external, internal, external, and intramural. This is, for example, for adenomyosis 2C, diffused intramural type. So before HIFU, we will say after we can see the very precise ablation, posterior and anterior also. So we will show our some cases here. So first is focal adenomyosis. And after HIFU, we will see the coming to the small, the right shape. And this is second case, also the posterior adenomyosis. 1 day after HIFU, we can see mostly ablated by HIFU. And after nearly 3 months, we can see the small size. And this is the first one. So first one also the focal adenomyosis. So we can see posterior lesion ablated very well, and this is not very good one. And this is another case 5. So we can see the mostly in posterior adenomyosis, and 16 months later, so smaller, much smaller. And this is case 6, also the adenomyosis. We can see the heart-shaped ablation here. So third picture is after 3 months. The size of the uterus much smaller. And then we did hysteroscopically ablation. We exclude all the tissue from the uterine cavity, and right side picture is clean uterine cavity, and we put Mirena. For this step, we can get tissue from adenomyosis, because some doctors said HIFU, the big thickness is no pathology. So this is also the good way we got tissue to do pathology to exclude malignant disease. So this is surgery we did recently. So for the patients after 40 years old, we usually do resection of endometrium. This is also the one type of treatment before for adenomyosis. So this first video for the anterior resection of endometrium. Second video is posterior of endometrium, and we will do some, this is for nearby the cervix. So after this step, the patient will not know any menstruation. So for adenomyosis, the choice sometimes is menstruation or uterus. So there are no menstruation, they will know any pain. So we have very good educate for our patient, tell them the adenomyosis is a chronic disease, uncurable disease. We need to do long-term administration. So if there are no menstruation, like pelvic vampire, there are no blood and then no adenomyosis. This is a diffusion adenomyosis, and we will see this is also the diffusion one. Here is some myoma cases. We can see 3 months later can shrink very well, very small. And this is also myoma. And this is a very good example for submucous, the very big submucous myoma, but it's very hard to take it through hysteroscopically one time. So we can combine with HIFU. Like Dr. Lee mentioned, the very good case is similar. So after 6 months, we can see the very tiny, smaller submucous myoma here. So we can take it through hysteroscopically easily. And this one is also our very typical and beautiful arts. So 5 millimeter myoma, after 5 months, we can see they are nothing. That is a magic. And this case, we can see the myoma also after 8 months smaller. So we have a very hot discussion just now. So the doctor's asking how long time the size of the myoma can shrink. But usually half a year or the 8 months, the myoma sometimes can disappear. But it depends on the patient situation. This is for multiple myoma. We will see the very big size of the uterus shrink very well here, the first and the third one. So we can see smaller. This is our field cases. Also, the doctor mentioned the HIFU cannot replace the surgery. That is right. For this kind of cases, we never choose HIFU now. So that is our experience. This is a cellular leiomyoma. It can recurrence very soon. We did a hysteroscopically operation already. So this is also the diffusion uterine myoma we already shared before. And this is for cesarean scar pregnancy imaging here. So after HIFU, we will see the ablation is very well. Here we throw hysteroscopically, we can see the very good vision here. So we take the chronic Relly sample. And this is a pancreas placenta agrita. This is a very good case also we did recently. So we will see after 4 months later, the uterus beautifully recovery. This is also placenta cases. So this is for abdominal wall adenomyosis, is also the hard one. So we will see 1 day post HIFU, we can see the ablation, the small lesion here, after 6 months disappear. Only the very slight scar here. So this is also the for adenomyosis. So this is our first HIFU baby. So we can see before operation, the myoma shrink very well. It will not influence. And we build the caring uterus club with patient and with doctors. So our CCs, we build a 5 WeChat group for patients, answer the question day and night. And our patients said, oh, there is a very good relation between doctors and patients. So through my WeChat, we can see nearly every outpatient time I can receive flowers from patients. This is our 1,000 cases HIFU baby. We celebrate 1,000 cases 2 years ago. This is in Chinese patient service platform. We have many medium platform for patients. We have day and night answer the question. This is our colleague. She has adenomyosis, very pain, and she seek the many ways to find many doctors, and she had finally find HIFU, and she feel herself can alive. So this is my colleague. I got permission from her to share the picture. So she said the trust of the patient and the peers in driving first for us to move forward. So this is a picture from my youngest son. I have a little son. He can paint some of picture. So protecting the uterus may defend the dignity of women. So we have many patients, they wouldn't like those uterus. So finally, I want to share the Mother Teresa's word. We can't all do great things, but we can all do small things, very tiny small things with great love. So I hope thanks again for all of you, especially Dr. Lee and Professor Relly. I hope all of you can have very safe life in the special time, and welcome in the future. After virus disappear, we can meet in Shanghai or meet in somewhere.
Hopefully.
And I went to Bali 2 years ago with my little son. So I feel the Jakarta had Bali also the very beautiful memory for me. This is Lisa from local Bali. So welcome to Shanghai.
Okay, thank you very
so much.
Ellie, for your nice presentation. We come to the discussions. In HIFU procedure, when the optimal time to treat myoma in reproduction women based on menstrual cycle? Prof. Aili?
Yes.
In HIFU procedure, when the optimal time to treat myoma in reproduction women based on menstrual cycle?
after menstruation, but it is not a very strict requirement for HIFU. They are not bleeding exclude pregnancy because we meet one lady, she taking the COS, and we recommend she accept HIFU after menstruation like 1 week, but she refused. She think herself will never get pregnant again because she had a very severe adenomyosis. She want to have a second child, struggle for 10 years. She never pregnant, and she insists on. She said, I will do HIFU very quickly. I wouldn't like wait for my another menstruation. So we did surgery, but after surgery 1 week, we found that she was pregnant already 1 month. But the embryo will not get any damage. Very, very nice. We have some cases, they had a normal delivery after surgery. But usually we will require patient to accept HIFU after menstruation. 1 week, like general surgery. Usually we do many surgery after menstruation. 3 or 7 days, during 3 or 7 days, it will be safe.
Okay. What about the pregnancy outcome after 3 steps treatment of GnRH agonist, LNG IUD, and HIFU? Is the patient
Yeah.
able to conceive naturally or
yeah, I see. The very good question. Actually, we are doing this kind of surgery. We have no very precise, specific data, but we feel the side effect of the HIFU is easily can pregnant. I share many cases in China to my colleague. We have a 45 years old patient. Actually, she already gave up pregnant again, but after HIFU, she pregnant 2 times. First time, I haven't get any message from her, and she herself did the abortion. But one second time, I said abortion is kind of sin. Please keep this baby that is from God or some Allah. Please give this baby the life, and she delivery. She finally did not accept the cesarean section. She had a normal delivery in her 45 years. It's very rare in China. After 40, usually the lady wouldn't like deliver herself, usually accept the C-section. But she did normal delivery vaginally, and the baby is a beautiful girl, very like angel. And she said to me, she is in Fujian, in another province far from Shanghai. But in our hospital, any HIFU baby born, I will be the first person to see the baby. But this lady living in Fujian, and she told me there are 5 doctors monitor her when she had the delivery. But she is very nice now, not any pain, very good.
Okay. Is there any data of incidence uterine rupture, which is compared between HIFU procedure and myomectomy?
Yeah, very good question. It's a very good one. So for also, I saw the question in the chat room. The side effect from HIFU is skin, the burning, and the bowel injury, and also the nerve injury. But for the uterus rupture in our center, my patient would not happen. Inshallah, I hope never happen. But we heard some cases happen, but very rare. But this HIFU is not the HIFU from Chongqing. We have some fake HIFU in China. We have several factory. They produce this kind of HIFU machine. They call it HIFU, but it's not significantly like Chongqing HIFU. It cannot. Some doctor cannot perform the very precisely, maybe. So we usually will control the rhythm of the procedure. We will not get hurt for the normal abdominal wall, and also we will protect the endometrium. for the patient have a desiration to pregnant again. So in our center, we never meet any rupture patient, but we have some colleagues, they do adenomyoectomy after laparoscopic and after abdominally. Last year, 3 cases. 1 case is happening in our hospital. The uterine rupture, the baby was died. Another 2 cases happened another big hospital. Laparoscopically adenomyoectomy. So I hope we will never meet uterine rupture. It's not easy happen if you control the energy and the procedure well. It's like electric curve. It's like art. So you can control the minute, 1 second, stop 3 seconds, and every time 5 times. We call this 1, 3, 5 reason.
Okay, can we perform vaginal delivery or right to cesarean sections for HIFU treatment?
Yes, we. Beg pardon. Wait, can you repeat your question again?
I mean, if the pregnancy after HIFU treatment, is it should be cesarean sections or can we do vaginal delivery?
Oh, very nice. Very good question. It depends on the real situation, the pregnancy going on. But HIFU is not indication or any influence factor for must do C-section. It depends on the real situation. The patients in our center mostly vaginal delivery.
Okay, it depends on
the
okay.
Baby size, everything.
How big is the maximal size for HIFU treatment?
I actually answered in the chat room already. The size is not the big problem for HIFU, but up to now, like Professor Zhang Li answered, we control less than 15 centimeter. We should control the treatment area. So usually lower than umbilicus level. Is the myoma very big, higher than umbilicus level, like Professor Zhang Li mentioned? The biggest cases is the world now is 22 centimeter. But for the very big size, we usually use JNRHA first to shrink the size and then do HIFU. So we combine the different medicine. We combine the traditional treatment with HIFU. We can use freely. Just keep the patients safe and keep the uterus. The final purpose is to keep the uterus.
There is the questions from Subagio. Is HIFU machine just the same as usual US ultrasound, USG?
USG is monitored by MRI. That is a different. Monitored by MRI, but I never this kind of machine before. But I saw some good paper to write the difference between USG and the Chongqing HIFU. For USG, monitored by MRI, it's like you close your eye for driving 20 seconds like. But the picture will coming a little bit later. So for ultrasound guide HIFU, like also the Dr. Lee mentioned, a very specific good mechanism. The ultrasound monitor, you can find any change during second. So you will change, follow patient's breast position. If the patient needs to move the body, we will rightly stop the procedure.
Okay, thank you. Actually, there's many questions, but in the chat box, but have already answered by the Prof. Aili and Dr. Nadir. Even before Prof. Aili make the presentations. So maybe, oh, this one is limitation of how many times we can do HIFU in, sorry. Okay, I would like to.
Already answered, I feel.
How many times we can do?
There are no the limitation actually for the how many times. We usually finished one time, but for the very big myoma, is for myoma the biggest one. If the level higher than umbilicus is beyond on the range of the treatment zone, so we will do second time or third time. For the DOL, the diffusion leiomyoma, this kind of cases is coming again and again. So we will do the second time. We have some cases we did the second time. It's depending on the size of the myoma or the size of the lesion. But for adenomyosis, we usually finish the only one time. If you can control the energy and you do the good evaluation before operation, and you can make a very good plan or strategy for the patient, actually we can successfully finish the only one time.
Okay, how many percent HIFU can reduce recurrent myoma and adenomyosis based on size, single or multiple?
Very good question again. Our recurrence now is 500%. We have cases 500% now recurrent. But these patients, they want to accept HIFU again. They wouldn't like to do surgery. Also, I have many patients is medical staff. They like some gynecology colleagues, they have adenomyosis, but they come to me find the treatment. So that is a very important thing. Get good trust from patients or colleagues. The recurrence is very lower compared to the surgery. As we know, the surgery adenomyomectomy is harder than myomectomy.
Okay, what about area for the ultrasound beam in HIFU? Is it same with the area for radiation therapy in cancer, or it's targeted beam?
The questions means for the ultrasound beam is for adenomyosis different from cancer? Or?
Is it the same area like radiation therapy in cancer, or it's
same? I feel the mechanism may be the same to some extent. So okay. It's through the outside to destroy the disease. The same mechanism.
It's targeted.
Yeah, we can understand like this. Yes, okay. Right.
Okay, thank you. Maybe any questions or comments from Professor Lee as a panelist?
Okay, a few things I want to add to help everybody to understand HIFU, because when you do HIFU, there's a bowl of water below the body, so definitely you don't do it when you're having bleeding. So whatever means you have to stop the bleeding first before you do the HIFU. Now, this is my appeal to Professor Aili, Zhang Lian, and I know Professor Aili is one of these specialists in the group called Endometriosis Society of China, and your good friend Professor Kwok is also there. Maybe for us, using HIFU for adenomyosis, probably the best is to understand diffuse adenomyosis, what's the success rate, and local or focal adenomyosis, what's the success rate, and this would help us clinically when we advise our patients. I know we do a lot of classifications of adenomyosis and too many, but doing research on all this classification of adenomyosis is actually good for the researcher or the person who writes a paper. Not really useful in practical terms when we advise patients. So maybe I'm a bit old in this. My thinking is different. Even my junior doctors think I'm very ancient, but I still believe what is more important is what can we deliver to the patients and not what we can write a paper and have our name on it to show everybody. Now, there are lots of pre-operative preparations for endometriosis or adenomyosis. And well, in my practice, I see very few deep infiltrating endometriosis. So it is good to talk about it. It's good to talk about it like as if you are the front man, the lead singer or lead guitarist in a popular band. But in essence, actually, we really just do a vagina examination, feel the nodularity in the posterior fornix to feel whether there are any endometriosis or adenomyosis spots there. And then whatever operations we do or treatment we do, we just rely on that. One important point is for doctors like me who does HIFU and I don't do IVF, you experience a lot of my colleagues who are in IVF with patients adenomyosis sent to me to treat the symptoms, to shrink the adenomyosis, and then I send it back to them for their IVF. So you get a lot of patients being referred to you if you don't do IVF. Also, somebody asked about HIFU. What sort of HIFU? Now, the HIFU that Chongqing uses is ultrasound guided HIFU, and it's meant for general obstetricians and gynecologists. It is different from the MRI guided HIFU that the radiologists will use, because the radiologists will use MRI in their X-ray department, and that occupies a lot of time. So, and you actually occupy the whole MRI machine. But in ultrasound guided HIFU, you just need a copy of the MRI report and the disc and feed into the machine to guide you when you do the real-time ultrasound guided HIFU. In fact, when I visited 5 centers in Korea, the machines are put in shopping centers or medical floors of the shopping centers. They are not in a hospital base. So you can actually put your ultrasound guided HIFU in a room that is away from the X-ray department. Okay. One last comment I would like to make is, we have a lot of patients seeing us for fibroids, small fibroids, 2 centimeters, 3 centimeters, 4 centimeters. And as they grow after 4 or 5 years or even 10 years, and then we advise the patient to do a hysterectomy. Now, usually these are not the patients who are willing to accept hysterectomy, because if they accept hysterectomy, they would have asked you to do a hysterectomy long ago. So many of you ask, what is the rate of reduction of fibroids or adenomyosis after HIFU? Something for you to think about is for the young patients, let's say when they are 30 years old, not married, and still waiting to find a husband and to have babies. I think one of the first concepts we should think of is to stop the fibroid from growing, even if it's 3 centimeters or 4 centimeters, because by the time the fibroid grows to 6 centimeters, 8 centimeters, and by the time she managed to find a husband, it's a long way down the road. So my concept has changed a lot in private practice. That is, it is actually geared towards delivering the best treatment for patients. So when the patient has 3 centimeters, 4 centimeters, and worried about fertility, it is a good consideration to do HIFU, because you can always do the surgery much later. And there's another question to ask why I say HIFU cannot replace laparoscopy. Can I just show you my 1 or 2 slides. A patient I turned down. Can you show the slide? I share the screen. Right to the end. Some more. This one. Okay. Okay. Okay, next one. Okay, let me just go back. No, why do I say the answer is no? That if you have learned how to do HIFU, you still need to have your basic surgery, whether it's open surgery or minimally invasive surgery, is because, I give an example. This is a 48 years old, and she always complained of swollen legs on walking and standing. She saw the cardiologist for heart failure. The cardiologist says no. She saw the renal physician for any kidney problem. They say no. But what happens is she has a, when I saw her, this is the uterus. This part is the cervix. And what she has a fibroid growing out posteriorly from the cervix. Okay, it comes like this. Somewhere in the internal os, her fibroid grew out here and compresses on the venous supply, the blood supply to the lower legs. This is the backbone, the coccyx. And I told her I would not do HIFU for her because it has to go through all the way to the back. And if I'm not careful, the rectum is here, the nerves are here. So for me, who has just started HIFU for the first 2.5 years, I would not attempt to do the HIFU. Maybe Professor Zhang Lian or Professor Aixingzi, who has got more experience, would do. So what happens is I brought her in and did a laparoscopic myomectomy. This is the fibroid that extends from the right to the, or the left to the right of the pelvis, compressing on all the veins. And this is attachment at the lower body of the uterus. So the moment I remove it laparoscopically, stitch up, I see empty space here, and the blood can actually returns to the lower limbs, and the blood from lower limbs can go to the upper part of the body. So immediately after surgery, a few weeks later, she came to see me and told me she's completely cured of her leg swellings. The other group of patients I advise and I don't do is those with pedunculated fibroids, and I tell them if I treat the HIFU may drop off in the abdominal cavity. So I always said you'd probably be good if you go for laparoscopy and laparotomy. So I just want to share with you my recent experience of why I turned down patients with for HIFU and go back to the usual surgeries. Thank you so much.
Okay, thank you, Professor Lee. We came to the end of the webinar. If there are more questions from the participant, can ask to the speaker personally by email or by WeChat. Yeah, Prof. Aileen and Prof. Chang Lian and Prof. Lee, Prof. Relly and Dr. Ichnandy. Okay, we come to the
Dr.
discussion.
Eddy.
Yeah.
Can I give a comment for the speakers? Thank you for our speakers, especially for the China and Singapore has used the batik in this afternoon. I'm very grateful for that. Thank you so much.
Okay, we come to the closing remarks by Dr. Relly, please.
Okay, thank you, Dr. Eddy. Especially, I would like to thank to all speakers has sharing the experience and knowledge for us about the HIFU. And hopefully after this seminar, after this webinar, we can know about more close information about the HIFU, because HIFU, I believe in the future can make alternative treatment, especially for fibroid and adenomyosis. And also, I want to special thank to company who supports this meeting, especially for the HIFU company and Triadi Lintas Persada company. Both of them has support everything from this meeting before the seminar and during the seminar and after the seminar. And thank you, and also for the all participants. Thank you for your coming. Thank you for your joining on this Zoom meeting, and hopefully you can improve your knowledge about how to treatment fibroid and adenomyosis with the HIFU. Thank you. Back to Dr. Eddy. Thank you, Dr. Eddy.
You are very welcome. Thank you. Excellent. Very excellent meeting.
Yeah, photo
today.
sessions.
Congratulations.
Yeah, thank you, Prof. Aili. Especially for your clothes. I impressed your clothes. It's from Bali.
This is from my Bali, from my students, Randy.
Okay.
I feel Randy also in the net now. I have students from your homeland.
Oh,
I have some very beautiful memory about Jakarta, Bali. Very nice. I hope you are all very well and have a good life.
Looking forward to have you here in
you.
Jakarta, Prof. Aili.
Thank
Looking
you.
forward.
Thank you.
Is there any photo
Also
sessions?
for you, Prof. Xiang.
Is there any
Yeah.
photo session, Dr. Relly?
Yeah. We have. Yes. Can we take a picture? Everybody can show off the face. Open your video. Open your video.
Open your video.
Open
Please,
your video.
Dr.
Smile, everybody.
Dr. Edwin.
Keen Whye, smile, Prof.
Okay. 1, 2, 3. One more.
Okay,
Thank you. Beautiful.
Okay.
Thank you so much, Dr. Lee. Very good, beautiful kissing done.
Bye-bye. Bye-bye.
Bye-bye. Thank you, everyone.
Everybody. Thank you so much.
Thank you so much. Very successful
very much. Okay.
meeting.
Bye.
Okay. Oh, how do I get out?